Welcome to the Regulatory Talks webinar, Insulin Dose Adjustments for Dietitians in Ontario. We're glad to see you all here today. I'm Diane Candiotto, Practice Advisor and Policy Analyst, and I'm joined by my colleagues, Samantha Thiessen, also fellow Practice Advisor and Policy Analyst, Carol Chetwell-Singh, the Director of Professional Practice, and Shrina Wynn, our Professional Practice Program Administrator. Before we get started, just a few housekeeping items that we want to cover. We invite everyone to share questions and reflections through our Q&A feature. The questions will be visible to us as organizers, and if we respond to your question live or written, it's shared with the group. The lines will be muted for all, but if needed, we can always unmute the line, which may be useful to clarify a point. We'll use the chat where you can share your thoughts and interact with us, and we'll moderate what we're hearing from the group. The chat is visible to all, but because of a large number of participants joining today from across Ontario and perhaps outside of Ontario, you may not see all the comments. We'll do our best to get to the comments, reflect and share as feasible with our time together. But in case we don't get to your question or comment, you can always reach out to us through the Practice Advisory Service. We'll review any outstanding questions that we may not be able to address and respond to you via email or through our FAQs that will be shared in Practice Advisory Resources. And if you're viewing this recording at a later time, the poll, question and answer, and chat are not visible. But of course, we have the content on the slides and we'll state the questions so you'll be able to hear them. Next slide, please. At the college, we recognize that we're all continually learning how to partner meaningfully and respectfully with First Nations, Inuit and Métis peoples, system partners, organizations, and many communities across Ontario. As part of this journey, we're working together to enhance cultural safety and cultural humility. Today, we're all gathering virtually from a variety of places across the country. And I'd like to acknowledge the traditional territory of our home office, the College of Dietitians of Ontario, which is located on the unceded traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and Wendat peoples. Home to many diverse First Nations, Inuit, and Métis people, also known as Toronto, it is covered by Treaty 13 of the Mississaugas of the Credit. We're acknowledging the traditional keepers of these lands as part of our deeper commitment to Ontario's Indigenous communities. As provincial health regulators, we play a role in reconciliation to meet the broader goal of public protection. I'm grateful to work and live here, and I'm grateful for the teachings I've received from Indigenous peoples and the enduring presence of First Nations, Inuit, and Métis peoples across this land. And I know many of you are joining us from various places where we'd like to invite you to reflect on the traditional territory and original inhabitants where you do reside. And we'll pause for a moment of reflection to reflect on the land where you're located as we all actively embrace the journey towards advancing the process of reconciliation. So just pause here for a moment of reflection. Thank you. Next slide, please. So today's session is approximately an hour. We're here to share and create space for reflection and learning, and we're discussing the recent council-approved position statement and practice guidelines together. Samantha will be sharing links to the resources, and of course, you can always find these on our website after the session. So I'll provide a brief overview of what we're covering today. We're going to talk about the context and position of the guidelines and controlled acts. We're going to go through key areas of the position and practice guidelines, followed by scenarios and guiding questions, and of course, our question and answer period. And we hope by the end of today's session, you'll leave with an improved understanding of the position and practice guidelines and the performance expectations of the delegation standard as you use and apply your professional judgment and apply these resources to your practice. And last but not least, before we begin, we wanted to thank dietitians, employers, regulators, who have provided input throughout this consultation process. Thank you, your feedback is invaluable. Next slide, please. Just a reminder of our mandate is that as a regulatory body for the profession under the Regulated Health Professions Act, we do have a duty to regulate dietitians for public protection and several objectives under the law. One is to develop, establish, and maintain standards of practice to assure the quality of practice of the profession. So these through policies and standards and guidelines to help guide dietitians. We also promote continuing evaluation, competence, and improvement of members. This is through the quality assurance program. So you want to think of the self-directed learning tool and the jurisprudence knowledge and assessment tool. This may be an area for reflection as you develop your learning goals for your upcoming self-directed learning tool in October during the renewal period. And to also promote the ability for members to respond to changes in practice environments, advances in technology, and other emergent issues. So providing education through this session helps us talk about professional obligations for practicing through delegation of controlled acts, and also aligns with our public protection mandate. And we're committed to ensuring that dietitians provide safe, quality care to clients, as you've been doing now and always during the pandemic as well. We want to thank you for the service that you've been providing and the care that you've been providing to Ontarians. Next slide, please. So we all know that many aspects govern our practice, from college requirements to ethics to organizational policies and the law. And practicing through delegation of controlled acts, the standard that we'll be discussing today, as well as disposition statement and practice guidelines for insulin dose adjustments, help us integrate knowledge, skill, attitudes, and behaviors in terms of utilizing our professional judgment when working with interprofessional colleagues, participating in and contributing to decisions that affect the well-being of clients. From here, we're first going to take a closer look at controlled acts. Next slide. So to provide you with some context and controlled acts, some of the background, we've noted at times through calls and emails and practice advisory that there's a bit of confusion on this topic, and it can be complex. So we thought we'd start off with a brief review so that we're all on the same page. Next slide. So let's talk about the controlled acts and the dietetic scope of practice. As you know, the Regulated Health Professions Act sets out 14 controlled acts, and these are activities that are considered to have the potential of posing a risk of harm if to clients or patients, if they're performed by unqualified individuals. We'll share the link to that. You can find the 14 controlled acts on our website. Our controlled acts apply to all healthcare professionals, and they can only be performed with legal authority. And one example is prescribing. Next slide, please. So generally, the legislation permits delegations of controlled acts, and so they can be transferred to dietitians in appropriate circumstances. I'm going to now launch a poll. So we have some poll questions for you. We can go to the next slide. And the first question that we have is, and I'll launch the poll. Just give me a moment. So what is a delegation? So you'll see here, the answers are A, a process where the authority to perform a controlled act can be transferred, B, defined in law, or C is a high-risk procedure. We'll give you some time to answer that, and then we'll share the results. All right, so I see the questions coming through. More seconds. Wait, I'm going to end the poll and I will share the results. Great. So well done. If you answered A, you're correct. A delegation is not defined in the law, but it's a process where that authority to perform a controlled act could be transferred. And again, a dietitian can perform that controlled act in appropriate circumstances and with a delegation. And it is the regulated health professional who is authorized to perform that controlled act who gives that authority to someone who is not authorized to perform the controlled act. The high-risk procedure is the controlled act itself. For example, communicating a diagnosis to a client or prescribing a drug. Great, we have another poll question, so we'll go to the next slide. And I will launch the poll again. Our next slide is, how is a delegation conferred or given? So is the answer A, a direct order, written or verbal for a specific client, B, a medical directive, an order for clients who meet certain criteria, or C, both A and B? I'll give you some time to answer. Answers are coming in. And yes, the polls are anonymous, not to worry. They're set up for you to answer them anonymously. And I will now end the poll, good job, and share the results. Great. So if you answered C, you're correct. Direction from one health professional who has the authority permits the performance of the order by another professional. So an order is essentially a direction, and orders can apply to tasks or they could apply to controlled acts. And so again, a dietitian would be authorized to perform it if it is conferred through an order or a medical directive. And those two types of orders, again, are just the manner in which the delegation could be given through a direct order for that client or a medical directive, which is a set of orders. And it's important to note that we can't perform a controlled act aside from skin pricking or in emergency situations unless we're delegated. But also important to note that just because we are delegated doesn't mean we have to accept that delegation unless certain performance criteria are met, such as having the competency to do so to perform the controlled act, and of course, that the controlled act is in the client's best interest. We're going to talk about that more when we review the delegation standard and when we talk about the performance expectations in the standard, which are the minimum expectations that we need to meet in practice. Okay, so we can move on to the next slide. So you might be wondering, why is this position required now? In the past, dietitians contacted practice advisory to clarify if a delegation would be required to adjust insulin. So we received questions. Is it prescribing if I give specific dose adjustment instructions? There was a bit of ambiguity about whether providing specific dose advice to an individual client in a specific situation would constitute the controlled act of prescribing. And the college was reluctant to give a definitive answer on the topic until this could be clarified. So we didn't have a position, but in the meantime, we advised dietitians that it would be, from a risk perspective, from liability perspective, it would be prudent to do so under delegation. Therefore, many dietitians may note that this is how they've been practicing all along. So what did we do? This topic needed clarification. We conducted a thorough policy analysis to confirm the position and to provide these guidelines, including environmental scans of Ontario health profession regulators and dietetic regulators, several focus groups with dietitians practicing in diabetes, performing insulin dose adjustments, and many consultations with colleges most affected by the position, legal counsel, registrant, and system partner consultations. And while it may seem that we've come full circle, this policy work has really allowed us to provide definitive guidance on the topic. Next slide, please. This is also a reminder that practicing through delegation of controlled acts was approved by Council in 2020, and it really sets the stage because it provides the performance expectations that articulate what are the minimum level of performance expectations when you're practicing through a delegation of a controlled act. And we'll share that as well, and you can find that on our website. We really cannot consider this position statement and practice guideline without the delegation standards, so they all work together. Next slide. Thank you. So with context and background on controlled acts, we're going to discuss the position and practice guidelines for insulin dose adjustments in further detail. Next slide. So as we mentioned earlier, the college regulates dietitians for public protection, and through our framework of standards of professional practice, this position statement is intended to inform and clarify our interpretation of insulin dose adjustments in dietetic practice. In addition, the practice guidelines in the document are to assist dietitians, their clients, colleagues, and employers with suggested best practice for insulin dose adjustments from a regulatory perspective. It's important that we stress and note that these practice guidelines are not intended to replace or be a substitute for clinical practice guidelines. So the document is not in isolation, as I mentioned previously. We really need to consider it with the delegation standard, again, for those minimum performance expectations. Next slide. The purpose of the position statement and practice guidelines are to clarify the scope of practice for dietitians in Ontario who care for clients with diabetes who require insulin adjustments, the difference between providing self-management education and prescribing, and that was a request through practice advisory for dietitians to receive more guidance on that, to clarify that. Also, our expectations, the college's expectations for managing risks and identifying and implementing protective solutions for safe client-centered services when providing education to adjust insulin doses. And lastly, the full role of the dietitian within the interprofessional diabetes care team. Next slide, please. So what is the college's position? It is the position of the College of Dietitians of Ontario that a dietitian with the required knowledge and competence can provide education to clients living with diabetes who are self-adjusting their insulin dosage. However, when that education becomes instructions with a specific recommendation to alter the dose of insulin, that advice would amount to prescribing or modifying a prescription for insulin, and that would require a delegation from a healthcare professional authorized to perform that controlled act of prescribing, for example, a physician. Basically, what we're saying is that if you're giving advice that's specifically altering the dose of insulin, the frequency, etc., if you're modifying that prescription, that requires a delegation, a direct order, or a medical directive. Next slide, please. So some of the key principles, again, that we're going to focus on is distinguishing between self-management education and prescribing. Again, back to those challenges that we have received through practice advisory, the calls and emails that we get, and then ensuring knowledge, skill, and judgment. It's not the college's role to tell you where or how, but just to ensure that if you're doing this, that you know that you need to be competent, of course, ethical and safe, and that would mean that you have the knowledge, skill, and judgment to do so. And lastly, that your role is defined by the needs of the client, the interprofessional resources, and the healthcare setting in which you are providing service. Next slide, please. So for those practicing in this area, you're likely aware, but nevertheless, all important for us to discuss with some background information on insulin. Insulin is a Schedule II drug. Schedule II drugs are only available from a pharmacist and must be retained within an area of the pharmacy where there is no public access and no opportunity for client self-selection. So we hear the term behind the counter. A pharmacist must conduct a client assessment prior to the sale of insulin to ensure that that drug is safe and appropriate for the client. And while insulin does not require a prescription, it is still prescribed. And if it is prescribed, it's prescribed by someone who's authorized to perform that controlled act of prescribing a drug. And dietitians in Ontario are not authorized without a delegation to prescribe a drug. Next slide. Now back to delegation, just a reminder of the delegation standard, which sets the minimum performance expectations. We can read more about them in the standard, of course, but briefly here they are on visual on the slide for us to review. So a delegation needs to be in the best interest of the client. We need to have the knowledge, skill, and judgment to accept the delegation. The third component here on this slide is being aware of laws where things cannot be delegated, for example, thinking about other laws in your practice setting. If you're in a hospital, for example, the Public Hospitals Act. We have to ensure that we meet standards for informed consent and record keeping. The important thing here is being aware also of accountability, quality assurance, and delegation processes in our practice setting. So we spoke earlier about how we don't have the authority to prescribe drugs under our scope of practice, but how we can be delegated that authority. And one regulated health professional can do that. If they're authorized to perform that controlled act, they can delegate to someone who is not authorized. We're going to go to our next poll question on the slide. We have a poll question on the next slide. Now, we often get this question, so I'll launch the poll. I'll just give you a moment, and then we'll read out the question here. So if you have a certified diabetes educator certification, do you need a delegation to perform insulin dose adjustments? Yes or no? I'll give you a moment to answer. Okay, answers are coming through. Great. Okay, we'll end the poll and we'll share the results. And the answer is yes, you still need a delegation. The CDE may definitely help dietitians ensure knowledge and skill to perform a delegated act, but a certification itself doesn't negate or remove the need for a delegation. So as you'll note in the practice guidelines, we encourage dietitians to develop their expertise and increase their knowledge and skill through education, cross-training, mentorship, attending workshops, conferences, seminars, taking courses, learning day-to-day on the job, and completing formal training such as the Certified Diabetes Educator certification or the intensive insulin management course, etc. But again, the fact that that certification exists doesn't doesn't negate the need that a delegation is required. Okay, we'll go on to the next slide. So this is where we're going to talk a little bit about clarifying educating versus prescribing. It's broadly accepted that providing general education to clients about its management, self-management, that's not a controlled act. Talking about the cause of diabetes, how activities such as eating, physical activity, administering insulin affect the disease, etc., and consequences of improper management. Even indicators of when insulin doses should be adjusted would be fine. We'll go on to the next slide, but the question I think remains is how specific can that educational guidance be before it becomes the task of prescribing? And we've been asked by dietitians to help distinguish that, and to support that, this spectrum has been created. So you'll note this in the position and practice guidelines. There's a figure on adjusting insulin doses, and it's on a spectrum. On the left-hand side, you'll see general education, again, generic education such as how insulin works, or getting more specific in education, but not, again, individualized. So, not giving that outright specific individualized direction. So saying something like generally the dose of insulin would need to be increased. That would be on the left-hand side of the spectrum, and that is done. That self-management education, that is not a controlled act. You do not need a delegation to do so. When you're moving towards the right of the spectrum, you'll notice it says under delegation. That's when you're giving dose-specific instructions under delegation. So that would be specific individualized directions, such as saying, increasing the insulin by 2 units to get to a blood sugar of 5 to 7 millimoles. So providing those client-specific instructions about dose modifications would be considered prescribing, and that's regardless of how that dose adjustment occurs, whether it be a change in pump settings, sick day management, calculations, percentage of total daily dose, whatever it might be. If you're on that right side of the spectrum, we advise you to do that under a delegation. Again, that delegation can be conferred through a direct order or a medical directive. And a reminder that we would need to meet the standard for practicing through a delegation of controlled acts. If you're in doubt about where you might be on the spectrum, whether that constitutes education or prescribing, our advisement would be that making any recommendations for dose adjustments under delegation would be prudent. I'm going to pause here for a moment. I'm going to check in for any questions with Samantha. And I don't know where I put my water, because I could use some water right now. But yeah, are there any questions at this point?
So I don't see any questions in our Q&A box at the moment. I'm sure many more will come through as we go along. So maybe it makes sense to move along into our scenarios, and maybe that'll prompt some more questions to come up.
Sounds good. Thanks, Samantha. All right, so we'll move on to part 3, our scenarios and guiding questions. So now that we've reviewed the position and practice guidelines, we're going to consider the standard for delegation, the performance expectations. We're going to apply this to scenarios along with some guiding questions. All right, so our first scenario on the next slide is the dietitian is providing education to a client living with diabetes who has discussed self-managing their insulin doses with their endocrinologist. The dietitian has a medical directive to adjust insulin doses. What should the dietitian consider? So this is where we can apply the position, the practice guidelines, and the delegation standard. And questions that you might ask yourself on the next slide, and these are in no particular order, but you might be wondering if the physician or prescriber has recommended or given instructions, advice to the client about self-management, thinking about if the client has the ability and interest to self-manage, thinking about your own knowledge and skill to provide education on adjusting insulin doses and timing, thinking about what's in the client's best interest, and any organizational considerations such as collaborative care, your practice setting specific legislation. So I think this always comes back to the concept that in this case, the dietitian has a directive. So that's how the delegation is being conferred through that directive for specific criteria for a set of clients. But even though the dietitian has that delegation in this scenario, they still need to consider if to meet the performance expectations in the delegation standard, do they have that knowledge and skill? If not, how can they work with their employer to obtain it? How do they work with their employer in the interim to ensure the client gets the care they need? So again, what's in the client's best interest? And we'll take a look on the next slide. Thinking about where we are in the spectrum here, and where am I on the adjusting insulin doses spectrum? Am I providing general education or information about diabetes and how insulin works? No delegation would be required there. Am I providing some statements of indicators of when a client should consider adjusting insulin doses, where an authorized prescriber may have already given instructions to clients to modify their doses? So, typically when a client sees this pattern of blood sugars, they would reduce nightly basal insulin so they can reach their targets. Again, that's more specific, not quite dose change, right? Not to the point of on the right side. So if we're on, again, that left side of the spectrum, no delegation would be required here, but on the right, where it's more specific, giving that specific dose recommendation where we're modifying units or frequency, the best advice here would be that the dietitian would need a delegation, again, conferred through their directive, and they would confirm that by reviewing what is in their medical directive. Those orders that pertain to their client that meet the criteria that's set out in the directive. So thinking about the spectrum on the next slide, we'll move along again, just asking ourselves, do I need a delegation for what I'm doing? If so, how will it be conferred? Could it be through a verbal or written order? Or do I need that through a medical directive that would pertain to clients that meet the criteria? Thinking about the standard. So even though I have that directive, am I meeting the standard for informed consent? Does the client understand the treatment? Who will be providing it? What the benefits are? Can they make that informed decision about risks and benefits? And again, that all is covered in our professional practice standard for consent to treatment. Accountability processes, so risk management, how do I minimize harm? Am I aware of what those are in my practice setting? How would I manage an adverse event? How would I check in with the client? What are the processes in my organization for delegation? We've heard, in terms of quality, we've heard some dietitians talk about having case-based learning in their directives for ongoing learning. And next slide, please. And again, just a reminder of the delegation standard. It doesn't have to be in this order, but of course, and there are no simple answers here. It can be messy to sort out, but considering have you met, if you're going to proceed, have you met all of the performance expectations in the standard? All right, I'll just pause for a moment. Check in if we have any questions, or maybe we can move on to scenario 2 and then see how we're doing. Okay. All right, we'll move on to the next slide. So this next scenario is about a dietitian providing education to a client living with diabetes who has experienced low blood sugar over several days. And the dietitian in this scenario does not have a delegation currently. So again, what should the dietitian consider? Thinking about the position statement, the practice guidelines, and the delegation standard. We'll go to the next slide. So the questions don't change. The physician may have already provided self-management education to the client, which we could see and ask and remind the client, thinking about their ability and interest to self-manage, thinking about our own knowledge and skill, of course, like we talked about earlier, what is in the client's best interest, what organizational considerations come into play in terms of collaborative care, your practice setting and the legislation in your practice setting. And the next slide, we'll take a look at the adjusting insulin doses again. Where would you be on the spectrum? For example, if you were to give guidance such as, talking about blood sugar pattern management and how generally insulin is reduced, to avoid lows. That would be on the left-hand side of the spectrum. Again, general education. If you were to give a more specific dose instruction, such as, reducing your insulin by 2 units, that would be on the right under, and we advise that under delegation. So that's where you might need to get a direct order in this case, if there's no medical directive in place, a verbal or written order from the authorized prescriber. So next slide. I've already kind of jumped ahead a bit to talk about that. So where am I on the spectrum? I've just covered that. But then also, thinking about if you need a delegation, how is it conferred? So we can move to the next slide, actually. And then, of course, not forgetting the other standards that come into place, like meeting the standards for informed consent, record keeping, and your risk management considerations. So without a delegation in this context, this is where dietitians may work with their employers or their colleagues to obtain a delegation, again, through a direct order, or in future developing directives. We've heard from some dietitians who obtain orders prior to seeing clients in their settings through referral or assessment forms, orders for delegated procedures, such as, for example, dietitian to titrate insulin up to 20% of the total daily dose, according to targets that are established by Diabetes Canada practice guidelines. In some instances, this may necessitate a referral to a healthcare provider who's able to assist the client, working collaboratively with the client, your colleagues, and employers to ensure the client gets the care that they need. Depending on the situation, might be a referral to emergency services. And in one case, we spoke about applying the principles of blood glucose pattern management for clients who are self-managing responses to high or low glucose readings. That was the middle of the spectrum, more specific, but not quite individualized. Given your low blood sugars, generally the dosage of insulin is decreased by an appropriate amount, like what you spoke to the nurse practitioner about, unless there are other reasons that you haven't mentioned to me. What did the physician tell you about decreasing your insulin, for example? The client may be able to say what that may have been. I usually decrease by 2 units if I see a pattern of lows, and that would be a way to self-manage and not prescribe. And the next slide, please. Again, just a reminder of that delegation standard. If we were to proceed with getting that direct order and through the delegation, thinking that it's in the best interest of the client, ensuring we have the knowledge, skill, and judgment, being aware of any laws in our setting, and ensure that we are meeting our standards for informed consent, record keeping, etc., processes of accountability and quality assurance in our practice setting. I'm going to pause here for a moment and check in with Samantha. I'm sure we have more questions at this point. I've been talking a lot, so anything that is coming up from the group.
You know what? It's a good time to pause, Diane. There is a question, and this I think would pertain nicely after this scenario. Someone's asking about emergency situations, and I'll give you a scenario. So say a dietitian does a new assessment on an older adult. They have well-managed type 2 diabetes, but they use basal insulin and oral agents. But the client is reporting to have nocturnal hypoglycemia, hasn't been seen by their endocrinologist, and the dietitian is not covered under a medical directive for insulin dose adjustments. Yet, but only when they see their endocrinologist. So the dietitian discusses the case briefly over the phone with the physician. The physician advises the dietitian to tell the patient to discontinue their basal insulin due to this hypoglycemia, and the physician will follow up by phone the next day. So when this happens, what does the dietitian do?
Yeah, I'm here, Samantha. I just stopped my video for a second. My apologies. I think you could still hear me though, right?
Yes.
Okay. So I think what I hear you saying is, can a dietitian take a verbal order for a medication adjustment in an emergent situation? Is that right?
Quite right. Yeah.
Yeah. How about we take a poll on this one? We can go to the next slide. All right, so I'll launch the poll and give you a couple seconds. So can a dietitian take a verbal order for a medication adjustment? I'm back. There's my video. Sorry. So I'll give you a couple seconds to answer that, and then we'll stop the poll and share the results. All right. Share the results. So it depends. If you got that, we don't have any restrictions for dietitians to take verbal orders, but you would need to consider your organizational policies if there are any restrictions that would prevent a verbal order. So verbal orders, we know, can expedite implementation of nutrition care plans and client-centered care. The Public Hospitals Act does state that verbal orders can be taken by a person who is designated by the administrator. So it could be a number of employees, including a dietitian. So you really just need to check your organizational policies as applicable to ensure you're following policy in terms of verbal orders. And if so, yes, of course, a dietitian may receive a delegation through a verbal order. For this scenario, would be one health professional who's authorized to do so is conferring the authority to the dietitian who is not authorized to prescribe. And in this case, it could be direct orders with instructions for intervention or treatment at a specific time that relates to that one client. And they could be over the phone, video conference, in person, written. And then essentially the dietitian would just be expected to follow the delegation standard, those 5 performance expectations, which we talked about. It has to be in the client's best interest. You have to have the knowledge, skill, and judgment, be aware of any other laws in your practice setting, ensure you get informed consent, record keeping, etc. And then accountability processes. How is this client going to be followed up? What does that mean, etc. So to recap, check your organizational policies and follow the delegation standard. Hope that answers that one. I think we have another poll on this because this comes up quite a bit in terms of emergency situations. Why don't we go to the next poll question? So can a dietitian perform a controlled act in an emergency situation? I'll give you a few moments to answer that. While you do that, I'm going to have some water. And we'll end the poll. Good job. And share the results. Yes. Okay. So yes, in an emergency, there are exceptions to rules permitting controlled acts to be performed in certain circumstances. So this would be like rendering first aid, giving temporary assistance in an emergency. If you were to grab a defibrillator and put it on someone, for example, or administering glucagon when someone's having a severe hypoglycemic reaction. And so we'll share a couple links. We have some articles and resources on this that can be helpful. And I think the key really in this situation is to think about, is it a risk of hypoglycemia or is it a hypoglycemic reaction, a severe hypoglycemic reaction that's happening in front of you? So if indeed there is an emergency for whom the person needs to get that treatment, they're suffering, they're at risk. If the treatment is not administered promptly, so we know that controlled acts can be performed in emergencies. We'd leave it up to the dietitian and their professional judgment, their organization to determine what is an emergent situation in the context of the dietitian's practice. If you're unsure, you can always be proactive to consult your organization's risk management, get legal advice on interpretation of emergency in the context of your practice, because we wouldn't define what an emergent situation is. But without a delegation, this is where dietitians may consider working with their employers and colleagues to obtain a delegation, which can be given through a direct order or directive. So that proactive piece, where possible, if in this situation, if needed, referring someone who is able to assist the client, whether it be urgent care, emergent care, to ensure that the client gets the care that they need. But yes, to recap, generally speaking, if your client is having an emergency, again, using your professional judgment to determine that, there are exceptions to rules that would permit controlled act to be performed in those certain circumstances, like giving first aid or temporary assistance. All right. How are we doing? Any other questions? Do we want to go on to the next scenario?
Yeah, we can move on to scenario 3, and then maybe we can tack on some questions at the end. I see quite a few.
Okay, great. Okay, so this next scenario, and I think this is our last one. A dietitian does not have a certified diabetes educator certification. Can they provide self-management education or adjust insulin doses under a delegation, a direct order, or directive? And of course, what should the dietitian consider? So this is no different than the other questions that we went through, applying the position, practice guidelines, and the delegation standard. So we'll go to the next slide. Again, you've now seen these questions a few times, just asking ourselves these questions. And there may be more to add to this list, of course, but has the physician or prescriber recommended or given instructions about self-management? Does the client have the ability and interest to self-manage? Do I have the knowledge and skill to provide education to adjust insulin doses and timing? What's in the client's best interest? So you might not have a CDE, but you've obtained knowledge and skill somewhere. Your employer may want you to have a CDE, and that's one way that dietitians obtain knowledge and skills. So again, thinking about your own specific situation in this context, what other organizational considerations come into play, collaborative care, practice setting, legislation, etc. Of course, thinking about the next slide, where you might be on the insulin dose spectrum. Is it general education that you're giving? Is it talking about blood sugar pattern management and general advice on the left-hand side, for example, or would you be on the right-hand side where you're giving more specific dose instructions under delegation, again, advised under delegation, where you're modifying the unit, frequency, etc. Next slide just kind of recaps what I just said, but how would you need a delegation in that context? How would you get it if needed? Is it through that direct order, verbal or written? Do you need is it through a medical directive? So again, not forgetting to meet your standards, of course, for things like informed consent and treatment, thinking about your accountability processes, your risk management, minimizing harm in your practice setting. Next slide, please. And let's not forget the delegation standard that comes into play, meeting those performance expectations. So regardless of CDE status or not, this spectrum and the delegation standard doesn't change. Having the CDE doesn't negate the need for a delegation, and following the delegation standard. It can be an employer requirement, and that again is one way that dietitians would ensure that they have the knowledge and skill. I think we have one more poll question. All right, so this is the last poll of the day. So I'll launch another poll, and this is just to summarize. So which of the following would include performance expectations when practicing under delegation of controlled acts? A, must be in the best interest of the client, and the dietitian must have the competence, the knowledge, skill, and judgment. B, must obtain client-informed consent, and the dietitian must be aware of legislation in their practice setting. C, must inform the delegating healthcare professional of any actions the dietitian took to manage any adverse events. And D, all of the above. We'll give you a few moments to answer, then I'll end the poll and share the results. Okay, I will end the poll now. Thank you for your responses. Thanks for your engagement today. This is an easy one. Yes, all of the above. So great job on that response. We'll go on to the next slide, please. So to summarize, we encourage dietitians to work with their employers and of course consider client needs, your personal competence, your knowledge and skill, interprofessional care, your professional obligations, such as the legislation specific to your practice setting or organization specific policies, risk management, including confirming your liability insurance coverage. You, of course, are in the best position to determine whether or not you're performing that controlled act, considering if you're giving those specific dose recommendations like modifying the unit or the frequency. And of course, there are no simple answers. There may be more questions. We hope that the discussion and resources and the position, the guidelines and the standard are helpful. And of course, individual circumstances vary depending on your practice setting and the nature of your professional practice. This may prompt you to ask more questions, and we're here to help find answers. We know that there's always a period of evaluation when there's a new guideline or position or statement coming out, and we want to hear what's helpful from you and what isn't. We will be evaluating this in 1 year to see how you're doing in practice with this. We also want to let you know that we're developing a public explanatory document that will help clients what to expect when seeing a dietitian for insulin dose adjustments, and can be helpful to explain delegation and the role in insulin adjustments to clients if needed. This is currently out for public consultation through the Citizens Advisory Group. This is a focus group of patients and caregivers that bring patient perspectives to healthcare regulation. And we'll share the link to citizensadvisorygroup.org. We will be updating you soon on this resource, so stay tuned. Next slide, please. And speaking of resources available, we shared lots today. Our jurisprudence and professional practice resources on our scope of practice page. That's under, you'll see the position and practice guidelines and the delegation standard. And for those of you that are developing medical directives or perhaps have them already in your organization, the Health Profession Regulators of Ontario have a guide to directives and delegation. So that can be helpful when you're developing or evaluating medical directives in your organizations. And that's through regulatedhealthprofessions.on.ca. And lastly, just a reminder, next slide, of our contact information. Oh, and we can actually move back, that's fine. The links are all here. We will share those links on our page, of course, and through our resources. And lastly, just a reminder of our own contact information on the next slide. Thank you. We will share a session evaluation. We do welcome your feedback. And again, you can always reach us through the Practice Advisory Service, either through our emails or phone. And we want to thank you so much for participating today, and thank you for caring for Ontarians. We do have Reg Talks coming up. They're quarterly. Their next one will be on writing goals for professional development and continued competence. That's July 12th and August 9th. And there will be more in the fall, so stay tuned for our emails. I think we have a few minutes left for some questions. What questions do you have? And I'll call on Samantha to assist us with the moderating, please.
Definitely. Thanks, Dan. I think there's quite a few questions. I'm just trying to sort of group some of the similar ones together. But I think one is looking for clarification. So what someone is asking is, could you please clarify, is delegation required if you are a dietitian with the CDE or Certified Diabetes Educator certification?
Yes. So if you hold that certification, that's great in terms of knowledge and skill. We encourage dietitians to develop that expertise, increase your knowledge and skill, and that may be done through many different ways, the CDE being one of them. But if you do hold that certification, you still need a delegation. So while that CDE may help ensure that you have that knowledge and skill, again, it doesn't remove the need for a delegation. I think what could be maybe helpful is thinking of an analogy in the clinical practice guidelines too. So for example, through the Diabetes Canada clinical practice guidelines, you may have data like an oral glucose tolerance test is diagnostic if someone has a parameter, has a result of greater than 11.1 millimoles. That means that, in terms of communicating a diagnosis, that would be data to support communication of a diagnosis, but we wouldn't communicate a diagnosis if we didn't have a delegation. Similarly, we wouldn't adjust insulin prescribed without a delegation. So I hope that helps to clarify it a bit. An employer might require it, the CDE, as a way that a dietitian has that knowledge and skill. But the key is that, as we saw through the delegation standard, to think about those 5 performance expectations and do you have the knowledge and skill to do so? And then if you are where you're at on the spectrum, if you're on that right-hand side providing a dose adjustment, a change in unit frequency, etc., then we would advise you to do that under delegation. So
Great,
regardless if you have the CDE or not, right? Yeah, I hope that helps. Okay.
Great. So there's another question about changing the timing of insulin. So someone is asking whether changing the timing of insulin, whether it counts as a dose adjustment, even though the dose might remain the same. and the frequency hasn't changed. So let's give an example of if someone is taking 20 units of Lantus at HS, could we recommend they take it at the AM instead? And so I think, you know, this may be, many of our examples use number of units to sort of describe like individualized specific dose adjustments, but maybe you could just speak to that.
Yeah, so what I hear you say, Samantha, is, for example, if someone's taking it QAM, the changing it to QHPM, whatever, is that modifying a prescription? Is that right? Yeah. I mean, all the controlled acts, whether it be prescribing, whether it be giving a diagnosis, performing a procedure below the dermis, they're controlled to mitigate risk and decrease harm to clients, and ensuring that those who are authorized and trained perform the tasks. The position that we have talks about changing doses. So we talked about, you know, dose change, frequency change. I think consider, you know, the insulin regimen itself, and consider what is changing. So if it's dose, route, frequency, any of that, you know, the first step, get clarification on your organization, what's covered, you know, in your directive, what orders, policies, etc. But I think if you think about the spectrum, if you're on that right-hand side of the spectrum and you're modifying the dose, unit, frequency, etc., you're modifying a prescription, the advisement would be that that is done under delegation.
Thank you. I think in the same vein of that question, there is another question about whether dietitians can do insulin starts, since it's just educating / teaching patients how to do it. And they're saying we're not actually administering the insulin. So I think it makes sense to go back to that spectrum again to maybe clarify that. Yeah.
Shireen, if you wouldn't mind just flipping back to one of the slides where the spectrum is on, but I think asking yourself the question, so am I providing education, general education, you know, versus, or am I giving a dose specific instruction that should be done under a delegation? So if you're teaching someone how to administer insulin, but you're not actually injecting it themselves. So again, teaching is not a controlled act, but the administering of it would be the controlled act. So again, you have to think about where you are on that spectrum and ask yourself, what am I doing? Am I giving general information, or is it very specific on the right-hand side? So again, hopefully that can help. Left-hand side teaching, right-hand side individualized specific changes.
That's great. Thanks for that. I think just kind of piggybacking on to that question, someone's asking whether this applies to non-insulin injectables. So I'm assuming they're referring to something like a medication like Ozempic, and how this position might relate to something like that.
Yeah, so I mean, the position and practice guidelines are very specific, written with insulin in mind. But I think here you would want to consider, you know, what drug is it? First of all, is it a scheduled drug? If it is a scheduled drug, we know that Schedule I drugs would be considered prescribing, and that would be a controlled act. And you know, any type of change, even if it's a non-insulin injectable like Ozempic, would follow similar principles, I think. So we would advise someone who is prescribing to do so under delegation. If you use any other analogy, any other drug, even Tylenol, for example, right? If you were recommending a dose change, we wouldn't generally do that. But let's say it's like 1 to 2 tabs, the client may be self-managing. But if you're suggesting a dose change and it's specific, that would fall under the right-hand side of the spectrum. So it would be considered prescribing. So I think, again, checking in with your organization, risk management, any policies to help you determine the most appropriate steps following the delegation standard. You know, the NAPRA drug database is also another one, that napra.ca, where you check drug schedules. But if in doubt, you know, give us a call. We're happy to chat it through through practice advisory as well.
Great, thank you for that. There is a question related to the controlled acts. And so we understand that dietitians have the authority to collect capillary blood glucose samples through skin pricking. And so someone is asking whether or not skin pricking includes helping a client with the application of some of those flash glucose monitors, like the Freestyle Libre sensor is one example.
Yeah,
we get the trickier one
sometimes. So I think the first thing to just mention is some of the flash glucose monitoring, newer technology. We can't interpret the law. Excuse me. We're not lawyers, so I don't know if inserting the Libre would fall under. But I guess questions to ask yourself: am I performing a procedure below the dermis? You can always check in with your risk management, your legal department for further guidance. So whether it would fall under a controlled act, or are you assisting someone with the activities of daily living, right? So we do have the controlled act of a skin prick for the purposes of monitoring capillary blood glucose. But, asking yourself, am I performing a procedure below the dermis? Is that different? That's where you'd have to get advice. Would it be assisting a person hand over hand with routine activities of daily living? If so, that would be fine as long as you have the competence to do so. And if you are performing a procedure below the dermis, if it's determined through your organization, then yeah, you would need that delegation, the direct order or directive, and following the standard, to ensure that you're meeting the performance expectations. But again, verbally providing teaching to a client who's fully aware how to insert the monitor would not be a controlled act if you're not inserting the device. You can always also work through the role and task framework. That is a resource that we have on our website, the RD role, ROLE, and task framework. That can be really helpful when you're facing new tasks in practice and you're wondering, can I or should I do this? There's 4 guiding questions that can help you answer that too.
Great. There's still a few more questions here.
Okay.
Hopefully
we're running a little over time, but
okay,
yeah.
Maybe we can squeeze in one more question and before we wrap it up.
Sure.
There is a question about in the diabetes clinical practice guidelines, there are a number of sort of suggestions that, for example, might give you the guideline to increase basal insulin by 1 unit per night until your target fasting glucose is obtained, something to that effect, they say. Since this is actually in clinical practice guidelines, is this recommendation on the right side or left side of that spectrum they're asking? So maybe some clarification on the difference between clinical practice guidelines and a college position and practice guidelines for dietitians might need a little clarification there.
Yeah, thanks, Samantha. Yeah, so the clinical practice guidelines are essentially there to assist dietitians with best practice, evidence-informed practice. And the practice guidelines that we've developed through the regulatory guidance to say, interpretation of that legislation and how that impacts practice. I think in the CPGs for diabetes, there's the example that I used earlier. There's also guidelines, for example, for communicating a diagnosis. If someone had that oral glucose tolerance test and they had that random blood sugar of 11.1, it's diagnostic, right? But you wouldn't communicate that diagnosis to the client if you didn't have a delegation. So same for for adjusting, if you're giving a dose instruction, to increase, decrease a dose specifically, if you're on the right-hand side of the spectrum, a dose, unit, frequency change specific to that client, giving that individualized advice. So when you read that statement, ask yourself, where is that on the spectrum? If it's on the right-hand side, again, prescribing, we would advise you to do that under delegation.
That's great. I just want to thank everyone for their questions, some really good questions. I'm sorry we didn't get to everyone's questions. Just note that we will be putting out an FAQ document for all the frequently asked questions that we hope to have up in and around time that we post the recording for the session. So if anyone is not able to attend it live, We will try to have these documents, the slides, the recording, and the FAQ documents up on our website as soon as we can. But thank you. Great questions, everybody.
Thank you so much. We look forward to seeing you at the next Reg Talks, and stay tuned for the recording and resources, which will be posted shortly. Have a great afternoon, everyone. Take care.
Bye, everyone.
Thanks, Samantha. Thanks, Sharina. Thanks, Carol. Bye.